Welcome to Straight Outta Health IT. Getting into health tech is rough, but here's an unfiltered dialogue of healthcare leaders and influencers covering a wide variety of issues affecting healthcare and the health tech industry. And now your host, Christopher Cunny.
Hello, everyone. This is Christopher Cunny, and welcome back to another episode of Straight Outta Health IT. Pleasure to have you back. And today I'm so excited to have on the show Dr. Jay Anders, MD. Dr. Anders is the Chief Medical Officer for Medicomp. He's one of the pioneers, quite honestly, in the development, implementation of electronic health record systems. He started in the early 2000s. Working in this space. I'm not going to tell his whole story. I'll let him do that. But he has seen this evolution in the use of EHRs happen. So I'm so happy to have him on the show to share his story, his journey, and get his perspectives on where EHRs have come from, where they are today, and where they need to go in the future. So that being said, let me introduce you to Dr. Jay Anders. Thank you so much for joining me on Straight Outta Health IT.
Chris, it's a very big pleasure for me to be on your show.
This has been a labor of love. I don't do the podcast for any financial reason. I am definitely using it as a platform to help others in the industry advocate for those things that they're very passionate about, also share their personal stories and journey in life and in our industry as well. I think out of all of it, just hearing others' journeys, challenges, triumphs, issues are just as important, if not more so, for listeners than some of the more academic and business-related conversations that we have as well, too. There's plenty of podcasts that do that. But I really appreciate the stories and journey that people have and why they're doing what they're doing, because there's always something behind their mission as well. So again, Dr. Anders, thanks for taking time to have the conversation. And what I typically do is, one, I'd like to meet, obviously, the guests before we get on the program to make sure this is something they still want to do after talking to me and vice versa. and then just in general, learn a little bit more about you and your story and your journey. And then what are you interested in chatting about it? And you've had a chance to I probably haven't had a chance to listen to very many of the podcasts, but if you have had a chance to listen to any of them, you'll see the topics range from a wide variety of conversations. That the term Straight Outta Health IT is really me being out of health IT, and obviously others who are in this space too. But the conversations really cover a wide variety of topics around the healthcare ecosystem. So it could be anything related to social determinants of health. It could be health equity. It could be technology and AI. It could be your own personal story and triumphing over some challenge that was healthcare related, patient advocacy, whatever, again, you're very passionate about. I try to stay away from, to some degree, a heavy pitch on products and services.
I get that too. I actually have my own podcast too, so I understand that.
Appreciate that. But that's a part of what we do too. So it's not that I'm not suggesting you can't talk about your company or your services, but I definitely try to stay away from it being like a heavy pitch. If people want to learn more about it, I give people an opportunity to share their websites or contact information, that type of thing. And if you do want to do that, which is quite, it's not a problem, then I do generally ask for some production fees at that point too, since you're basically advertising at that point. So
I won't be doing that today. No.
Exactly. So I'll stop there for a second and just, Dr. Anders, maybe you can just share a little bit of your journey, your story, and what you're interested in talking about on the program.
Okay. I've been in this part of the business. I started out as a general internist in a very large group practice, was president of that practice for the last 7 years I was there. Then got interested in doing healthcare IT. We had installed an EMR back in 2002.
Right.
When EMRs were not what they are today.
I was going to say, you're an early adopter.
We were an early adopter. And the company that we bought it from, as we were installing it and all that, they wanted clinical feedback. By that time, there wasn't a whole lot of us in clinical medicine that was actually given any kind of input to these systems.
Mm-hmm.
So they said, okay, I'll do some consulting, got a little bit larger and bigger and longer and more time. And then after about 2 years of that, I flipped and actually became their chief medical officer full time.
Which was, you were probably one of the first trailblazers in that space too. There weren't a lot of
pretty much
CMOs working for tech companies back then.
That being said, the reason I ever got interested in this was back before there were a lot of EMRs. An ER physician colleague of mine and I decided, let's make an ER EMR. It was a horrible disaster. Lots of money was spent, and we didn't get very far because you just how complex these systems are.
Oh, sure. Exactly.
So we dropped that idea.
Exactly.
Yeah, we dropped that idea pretty quickly. But that was my first little flavor into doing something like this. But once I got started in healthcare IT, it was pretty obvious that it really needed more clinical input in that industry because they were creating products for physicians and providers to use without ever asking them, what do you want? Or how do you do what you do?
Exactly.
That all converted into several acquisitions before I actually wound up at Medicomp, meaning I went from Integrate Systems to Med 3000, which is a billing and EMR company, to McKesson in their business performance services division. And I got tired of the big, huge corporation type stuff. And I had known Dave LaRoe for years. And he said, anytime you think you want to make a move, call him. So I did. And I'm now their chief medical officer. But I get asked a lot about why'd you do this? Why'd you get out of practice? Why did you go into this and full time? And I tell everybody the same thing. I really enjoyed seeing my patients. I enjoyed clinical medicine so much. I still have a stack of the cards I got when I left the clinic from all my patients. I keep them on my desk just to remind me of those days and how much the impact was. But I also tell folks back then I would see 6,000, take care of about 6,000 patients a year. What I do now affects the lives of hundreds of thousands of patients, hundreds of thousands of physicians. Exactly. So it's a much broader scope. And that's why I got into it.
Absolutely. Absolutely. No, that's great. So I love this conversation because I'm already thinking about a title and a journey here, but I don't want to. But if there's something else you're very passionate about talking about, please let me know. I'd love to talk about the kind of the evolution of the EHR. As it when you started, and where is it today, and where do you see it going?
That's a really good question.
Yes.
Back in those early days, EMRs were nothing more than I would call a lookup system.
Right.
You could see lab tests. You could see, maybe you see notes. Maybe you see where you can do an order or something very basic, but one way.
Right.
You look at stuff and you do things, but nothing really coming back to the clinician. Over time, they've gotten much more sophisticated, obviously, and much more robust. And now we're in the era of clinical interoperability, where we're sharing all this clinical data back and forth with folks, which I think is an absolutely marvelous idea.
Absolutely.
Because one of the things that was a big problem for us in the paper world, and it's still a problem in the electronic world, is how do I get those medical records for that patient that's standing in front of me or sitting in front of me so I know what their whole clinical picture is?
Exactly.
And we're just starting to take those steps. The ONC has done a really great job this year putting these standards around interoperability and how we're going to do all of this.
Sure.
But it's still baby steps.
Why do you think it's been such a challenge for our industry to exchange data? Do you look at other industries, whether it's the financial industry, automotive, you name, pick your poison, hospitality, everyone has figured out how to exchange information pretty effectively and pretty securely for the most part. Why is it that it's taking us this long to do this? A SQL database is a SQL database, right? We're not inventing any special technology, to the best of my knowledge, around data exchanges outside of standards that we put in place, HL7, FHIR, et cetera, around exchanging information. Technology, using technology to exchange information. But there are even technology we haven't fully embraced, like blockchain, that could have huge impacts on healthcare as well. Just curious from your perspective, why do we seem to struggle with this?
I think there's probably two major things that have been stumbling blocks for people. One is there was no standards. What information do I send and how do I send it? That is now starting to be clarified by the federal government, which is a great place. It's the only place it can go. They have to choose. How do we give that information from one place, get it from one place to another? The second issue is, I think, the old privacy and the issue of I don't want anybody to know my particular health journey unless they really need to, and I'm a little reluctant to share it. And not just at the patient level, but also at the clinic level. If you take a large medical practice or a large medical system, when you start sharing data back and forth, you learn a lot about what that system's about and how they do their work and what they're doing and things like that. And sometimes they think that's a competitive disadvantage to actually share the information. It's total nonsense.
I'm glad you shared. That's been, quite honestly, my view as well. I don't think it's a technology issue in many cases, as it is, to your point, a standards issue and a willingness to want to share data, whether it's from a privacy perspective or from a competitive perspective, of being able to try to keep your competitors away from your customers. And so ultimately the patients are impacted by that as well. Back when you started down this journey in 2002 to now, you mentioned working for McKesson, who at the time was probably the 1,000-pound gorilla on the block when it came to health information technology platforms. And back then, there were several other companies who were who had technology in place. Now, fast forward 20 plus years later, you've got just a handful, right, of EHR companies who are really dominating the market, that if you ask the average hospital, they're probably on one of 3 or 4. How do you feel about that? How do you feel about this consolidation down to a handful of major players who are really driving the innovation that's happening in this space? And so I'll just put a pin it right there. Just how do you feel about that?
You mentioned the word innovation.
Right.
One of the things I have seen with consolidation is actually a lack of innovation.
Exactly.
We're big poured concrete here. We've been doing it this way for 20 years, and we really don't care about what the provider needs, wants, or desires. So we're just going to give them what we give them because we're the safe choice. Those 1, 2, or 3, 4, 5 systems.
Sure.
They're the safe choice. So I think the consolidation has actually stifled a lot of innovation. And I think for 2 reasons. Number one, innovation's expensive.
Mm-hmm.
And when you're innovating, you're not really out there selling stuff.
Right.
So it's a competition of resources and everything else.
Yeah.
Which is really sad.
Exactly. Again, concur as well, too. I do think that innovation to a certain degree has been stifled because you've got a handful of companies that are really controlling the marketplace and aren't forced to, in some cases, to innovate because they can limit, in some cases, not even allow emerging technology companies to take a foothold in the marketplace because they manage the core part of it, which is the patient data. If you don't get access to the patient information, how can you put tools and technologies on top of legacy platforms to help make them better or to help innovate? It's unfortunate as well, too. And I'm sure you do attend a lot of different healthcare technology conferences and thousands of companies who are exhibit floors and have these booths. And you walk through here and you see all this great new technology that they're promoting and touting that could potentially change how we deliver care. You and I both know that half of those companies probably won't be around in the next 5 years or more because they won't be able to get access to APIs and integrate with these 5 or so major EHR platforms, and health systems are not going to want to talk to them unless they are integrated with those platforms. And that's the mantra. Are you integrated with XYZ? Oh, no, I'm not. Okay, I don't even want to talk to you because if you're not connected to one of these big guys, then we're not gonna consider you. I don't know if I have a question here, but just your comment. I'm just curious what your thoughts are.
I agree with them. They do tend to be very insular in their approach to healthcare and the actual provision of healthcare IT. It was amazing in the last 2 years, the whole, I'm going to call it the shiny brass ring, that is all of these large language model, GPT-like platforms now that have come out, and physicians are so hungry, providers of healthcare are so hungry to do something different. Better, less burnout, less labor intensive. Give me something back when I'm looking at these systems, that they've now had that promise that this thing can do everything. You don't need, that's wrong. We all know it's not going to happen that way. The other good thing about some of the governmental intervention with, especially when this for the information blocking. You talked about not willing to share the data. That is no longer something you can not share.
Exactly.
You have to. If you're a certified EMR, you're going to share your data. It's part of the requirements now for certification. So I think that is wonderful. So the big guys are going to have to figure out how can they get to the sharing part of this with smaller systems.
Sure.
And I'm really looking forward to it. I think there's a lot of people scratching their heads about, oh my, what am I going to do now?
Exactly. One of the things I find interesting also is if you look at these systems and the cost of them are just astronomical. And when you look at other verticals again, at the beginning phases of those companies' evolutions, yeah, the technology is relatively expensive, but over time, it starts to commoditize as more and more organizations acquire it. You figure out how to manage it better, so on and so forth. I don't know if I've seen that happen in this space either. Have we seen the cost of acquisition of EHRs go down or go up or remain about the same? What's your opinion about that?
I have seen them go up. Part of it is paying for what little innovation's been done so far. As they add things and more capabilities, of course, somebody's going to pay the cost for that. The problem I see, moreover, is the fact that the way systems are designed today, they don't give back to the provider anything, pretty much anything. They make it hard for them to find clinical information inside of their systems. They make it hard to get from a clinical encounter to an order or to a prescription. And I've seen, talk about prescriptions for just a minute, that was something I would do 150 times a day, write a script. Let's make that easy. Nope. We're going to try to make that as convoluted as possible, choosing the drug and making sure this happens and all that. You don't see the design to really help clinicians do their work.
Exactly.
Give them the information they need at the time they're seeing the patients and do what they have to do. Assist them in some way. It's more a one-way street. They're still focused on billing, focused on creating a clinical encounter, so that code can go out and get paid.
No, absolutely. And to your point, I don't see these technologies being developed in a very intuitive way. You look at your smartphone, for example. How many of us went to Smartphone University to learn how to use an Android or an iPhone, right? Or some of the basic applications out there at Facebook or LinkedIn, or you name your flavor of different applications that are in the marketplace. But yet, to your point, it seems when it comes to these types of technologies, it's still very much a challenge. There's an extensive amount of education and training that's required. And in some cases, even after that, the light bulb still hasn't gone off for some folks in terms of how to best leverage it or navigate them. And again, just my commentary, just curious what your thoughts on as a clinician as well. And then maybe pivoting and talking about what is the future of the next generation EHR? What should it be?
I think right now, one of the reasons we are where we are is there has been a lack of end user input, clinicians, providers, nurses, people who are actually delivering the care, their input into these systems as to how they need to be designed, what the workflows need to look like. People are still guessing and they're throwing things out there. And hopefully something will stick. This is the right way to go. Turning to what the future can give us, I think there is quite a bit of innovation that's focusing around this new large language model type input. And we're at the point in time right now where the federal government, the ONC, has said we've got to put some guardrails in this process.
Exactly.
It can't be just unbridled. Physicians need to know where things are coming from, and that's part of the new criteria they put out, things like that.
The efficacy, the data.
The workflows, I think, are almost going to become secondary to the encounter of a patient. Let me describe what I'm saying.
Sure.
There's this ambient listening technology out there now. There's 2 or 3 or 4 big ones that are actually doing a really good job of creating a conversation in text about what happened in an exam room. The magic occurs when you take that text and convert it into real data.
Exactly.
And once the data is there, all the other things that clinicians are required to do or have to do will be much easier.
Yeah.
I see that type of technology increasing patient satisfaction, increasing physician satisfaction, There's going to be some potholes in it. There's going to be some landmines in it.
Sure.
But I think that's where the future is going to be.
Absolutely.
Yeah.
Absolutely. And then also, I think when you think about virtual care technologies, remote patient monitoring platforms, systems that will provide real-time input and data that feeds back into these systems with AI, providing some level of analysis, analytics around it. And then hopefully we can become more proactive and responding to patients' conditions before they become acute. And I think there's the promise of that, plus to continue to deliver more care outside of the four walls of a clinic and a hospital to where the patient is at, patients in a medical home and other places where non-traditional places where healthcare could be delivered as well. What's your thought on that? And are you bullish about that? Or are you concerned in terms of your perspective?
I'm very bullish about it. One of probably the only silver lining of COVID-19 was the fact that it started to make people think I can deliver healthcare on a Zoom call,
right?
Or I can deliver healthcare on the phone. The interesting thing about that is I delivered healthcare on the phone 30 years ago,
right?
Because people would call me, I'd pick up the phone, call the patient. I didn't have all their data because I was at home, but I could diagnose, you need to go to the emergency room, I'll write you a prescription or whatever. So that's been going on forever.
Right.
Just never got paid for it.
Exactly.
Now they're starting to say, okay, this is valid care, which it always has been, and it should continue that way.
Right.
So I'm foursquare behind telehealth. Multiple touches with a patient has been proven over time in multiple studies to really help their outcomes. I'm all for that.
Exactly. To double down on that, we're not replacing the number of clinicians fast enough versus the ones that are actually now retiring or moving into baby boomers. I'm one of them as well, moving into our latter years as well too. And you've got less and less young folks moving into the healthcare profession. And so this dependence now on potentially on AI technologies to augment that lack of resources is something that's emerging. So I always think about this term, the digital doctor. In the future, you'll pick up a phone and you'll talk to an AI-driven system that can provide general primary care. It'll get your vitals on the remote patient monitoring devices that are built into your Fitbit, into your clothing, and into your house to measure your current conditions. And then it has access to all your medical records down to your DNA to understand who you are and to provide better precision medicine. And you pick up the phone and say, hey, I've got a fever and cough, runny nose, or get on my computer or my iPhone or whatever it is at the time we've got. And this digital doctor pops up and says, based on your vitals I'm reading today and based on other conditions, I think you have a cold. You should go to the pharmacy. I'm going to write and prescribe you some medication to address these issues. How likely is that to happen?
I don't think it certainly won't happen in the rest of my lifetime.
Right.
I don't think it's going to happen in my children's lifetime either.
Okay.
And here's the reason why. The practice of medicine is not all mechanical, meaning it's not written, here's a protocol for every single thing that can happen to a person.
Sure.
There's clinical judgment. There's clinical training over time, experience that comes into play. The things I used to teach residents and medical students when I was in practice, that when the visit starts, when you see that patient is when you see them walking down the hallway toward you and you're saying hello and how they sit down, how they stand up.
Sure.
There's a lot of that where AI is just not going to be able to do that kind of stuff. Do I think that it'll be more a part of everything? Yes, I do.
Sure.
We need things to filter information for us because all my patients had 4 or 5 or 6. I'm an internist, 4 or 5 or 6 problems. And getting through all the problems sometimes took a lot of work just because you had to find everything.
Exactly.
I think that's where these systems will come in and help the clinicians do that either over the phone or in person. But I don't think a computer, let's put it this way. Would you trust your wife or your children or anyone to be treated only by a computer?
It's a good question. We trust computers every day to navigate our way in across the through the air by getting on planes that are autopiloting us to the next destinations. Astronauts are trusting computers to get them from Earth to the space stations and to Mars and other places. We trust it in our finances. So we do trust technology on a day-to-day basis to manage our daily lives. I don't know. I think for me, the jury's, in all honesty, I think the jury's out in terms of as AI continues to advance and we start comparing its ability to diagnose a patient and versus a human being, what's the error rate? Is it just as high or is it lower? Is it about the same? And oh, by the way, now is that cost to make that call $25 versus as if I go see the human being, am I willing to take that risk on? Yeah, the jury's out for me on that. My human being side says, oh no, I want to trust another person because I'm tribal, right? I don't want androids taking over the world. But also, if I didn't even know it was an android in some cases, because AI has gotten so proficient, I might not even know I'm not even talking to a human being.
I somewhat agree with what you said, but being a clinician,
sure,
personally,
of course.
The other issue is when AI gets it wrong. And there have been times on the phone where I'm thinking, I'm going to send this person to the emergency room because I'm not sure about what that stomachache really is.
Exactly.
And it could be the fact they had a really bad meal, or it could be the fact they're having a myocardial infarction, and I can't tell the difference on the phone. I'm curious about how the computer's going to do that, regardless of how much information it has. But there's why I sit with that. I think it can augment practice of medicine tremendously.
Sure.
Replace?
Not quite.
Not so sure. I'm not quite there yet.
I'm not quite there either. I will say that at some point I do want to talk to a human being to validate, at the very least, what this technology had said and to sympathize with me in my situation, because I may want to discuss alternative treatments as well. And then just to have that human connection, I think it's still important to all of us to have a sense that humanity still has control of its own destiny.
Yes.
So what are you passionate about right now? What are you advocating for as it relates to healthcare technology, future of healthcare? What are you focused on? And then maybe you can share a little bit about what you're doing in your current company.
Okay. There's a couple of things I'm very passionate about. Number one is when I saw all this open AI type stuff coming out and people saying it's doing miracles, it's doing all of that. I'm really passionate about getting it right as opposed to getting it out there.
Sure.
And what that really means to me is these systems need to be very well trained on very good clinical criteria to actually do the work that they're thinking they can do right now.
Exactly.
That's one of my soapboxes for the last year and a half.
Sure.
The other's been a soapbox since almost day one, and that is, for heaven's sakes, please ask the people you're building these systems for what they want and what they need and how they do what they do.
Absolutely.
Now, we all do it a little differently.
Yeah.
That's okay. But at least ask us.
Right.
Because there's a lot of not asking out there right now.
Isn't that what the user group conferences are for? And
you know what? I got to tell you, a lot of user group conferences are nothing more than here's our new shiny thing we just built for you. It's not asking you what it was, but here it is.
Yeah.
And it's going to cost you 10% more. And that to me is not a user group. That's a sales process. And I think a lot of these are sales processes.
Yeah. Yeah. But good point.
So,
and then tell me about Medicomp and what you guys are doing and what's exciting, what's happening there.
Actually, we're working on one of the things is one of my passions. And I knew this company had it in it when I first started with them about 11 years ago. But with these large language models, we have a clinical engine that basically thinks like a physician thinks. Mm-hmm. So we are in the process of actually using these large language models to create the guide rails for them. So it's because we have a group of clinicians that have been working on this for over 40 years to create it that provide those guide rails. Mm-hmm. The other thing we do and do very well is that sorting of information to EMRs. And we're in several EMRs, but it's give me the striped view of diabetes for this patient. Show me anything else. Show me the diabetes part. Show me the hypertension part. Show me the chronic renal failure diagnosis. So how do you sort through, especially with interoperability being like it is? We're going to have a data tsunami. You're going to get all this stuff in, and how in the world is somebody ever going to sort it out without some type of technology to help you do that?
Exactly. Almost like the clinical brain of the EHR itself.
That's what we do and what we're working on right now.
That sounds great. We wrap this up. Any words of wisdom, any words of advice? You mentioned include clinicians and the users of the technology in the design of the technology. For those young folks who are coming behind us, who are having to solve all the problems we created, your advice to those folks?
I would say get involved.
Right.
Clinicians for the longest time just didn't want to be involved with it. They didn't think they were heard or whatever. Regardless of how you think or what you think you're doing with that, get involved.
Sure.
If you've got a system that you're working with and you don't think it works correctly, or you think it needs something else, by all means, get in touch with the people who make it and say, hey, here's something that doesn't work. I have an idea.
Exactly.
Get involved. The only way we're going to change this is when more of us in the actual using of these systems get involved. It's going to change. And I think it'll all change for the better.
No, absolutely. Thank you so much for taking time.
Thanks.
Thank you so much for listening to Straight Outta Health IT. We hope you enjoyed today's guest. For more unfiltered dialogue of healthcare leaders and influencers, be sure to tune in next week. For the show notes, transcripts, and resources, please visit Apple Podcasts, Spotify, or your favorite streaming platform. We invite you to give us feedback by reaching out to Christopher Cunny on LinkedIn, just searching for Straight Outta Health IT, and you'll find us. We are constantly having live discussions about diverse topics in the industry.